So I've been asked to give some discussions about some early detection of glaucoma. My discussion is not going to be about 10-2 or OCT or anything in terms of diagnostics. I just want to go over some cases where I felt would be of benefit clinically for the audience. I'd like to present three cases, inshallah, in this brief little time. The first is a 36-year-old female who presented in February of 2006. She had a family history of glaucoma, and she had strabismus surgery. Her corneal pachymetry was slightly above normal. Vision was 20/20, pressure was 21, and she essentially had a normal exam, and this is her optic nerve appearance in the right eye. It looks pretty healthy, it looks intact. You have a nice intact retinal neural rim, and maybe a cup the disc of about maybe 0.5 based upon contour. Now the other nerve looks a little bit more suspicious, looks a lot larger. You have a larger cup, and that makes us in the clinic a little bit uncomfortable as to what may be going on. But interestingly, when I followed her with visual field tests over a span of 6 years, she essentially had a normal field test. You can see for the left eye and right eye, essentially a normal field test. And it's important when you do assessment of patients with the questionable glaucoma that in your practice you try to obtain, if you have, an OCT. The retinal nerve fiber layer OCT will help you out in these kind of situations as to whether to treat or not to treat, because if you treat them, the treatment is for a whole lifetime. And you can see in the analysis, and I don't have time to go into a separate lecture, as to how you interpret an OCT. You have to look at the signal strength. She had a very good signal strength, 10 out of 10. The centration over the optic nerve is very important, and it looks very good over here. And you can see in the map below that essentially the nerve fiber layer thickness in all aspects, superiorly, inferiorly, nasally, and temporally, is within 95% of normal. And that's a little bit more reassuring as to whether we treat somebody or not. But the take-home message I want to tell you here is that when you have someone with disc asymmetry, at least in my practice in New York, I will see a number of patients who come in who presumably have glaucoma, but it's very important if in your practice, if you can, try to have the photographs of both the right eye and left eye side by side. If you have the photos side by side, you can see that there clearly is disc asymmetry, not glaucoma. So the larger the disc, the larger the cup. As you can see, the cup on the left side here is much larger than vertically than the cup on the right side. But overall, this is not glaucoma. And it's not uncommon in my practice when someone comes in that the patient's being treated in the eye with a larger cup to disc. So keep that in mind. So RNFL OCT is important. A second case I want to present is that of a crowded disc. We had a female from a Middle Eastern female who came from the family history of glaucoma, and she had hypercholesterolemia. Her vision was 20/20, and she had slightly high pressures in the high normal limits, and her corneal thickness was essentially close to normal. Her slit lamp exam was unremarkable. She had wide open angles, and again, her cup to disc was 0.2, and she came in, and the decision was made to put her on Lumigan, 1 drop at bedtime in each eye. If you look very carefully at these nerves, they don't look that remarkable. They look like about 0.2 disc to cup to disc ratio. They're crowded, maybe 0.1, 0.2. And then I just, as a baseline, because of her family history, I obtained a visual field test, and you can see that in her left eye, she has an inferior arcuate scotoma on your left side here, while the right eye didn't show anything. And of course, one of the things we learned from clinical trials, particularly the ocular hypertension treatment study, is that when you have an abnormal visual field test, you always try to repeat another one within 6 months, because what they've found in that study was that over 86% of the patients who had an abnormal and reliable visual field test on repeat, their visual field test was normal. So you can see here on repeat, indeed, she had the same abnormality 1 month later. So this is not some type of a learning curve here. She was a very good test taker, and that was very alarming and concerning for me, particularly when you see the cup to disc ratio was within 0.2. And we did one more about a year later, showing you that this is very consistent. And you want at least 3 visual field tests to get a baseline if you're not sure. And clearly she has an inferior arcuate that's without a doubt real. If you look at these nerves again, essentially just looking at the cup, just look at the optic nerve itself. It looks pretty good. You don't see any abnormality here. But there's a take-home message here. If you look very carefully, I'll go to the next, and I don't know if this pointer works here. So if you look carefully on the optic nerve in the left side, you'll see that there's a whole sector of nerve fiber layer missing superiorly in that left eye. I don't know if you could turn the lights down. That might make it a little bit easier to see here. And she had clearly in her right eye, which is her healthy eye, was essentially normal. And the left eye, you can see, is dipping in the superior aspect into 1% of normal because, the red disease. And you can see here that she had an abnormality in the upper part of that left eye. I don't know if you could dim the lights. Is it possible I can request that? If you look on the left side again, you can see there is a missing of the nerve fiber layer superiorly. And so clearly there is loss that's taking place over here. I think it might be a bit more impressive here if you look carefully superiorly. There's a whole nerve fiber layer missing, we call bearing of the retinal vessels. And the take-home message here is that just because someone has a normal optic nerve, the rule of thumb is usually you have cupping before you get visual field loss. Right? You have optic nerve damage, you have sloping, cupping, and so forth before you have optic nerve loss. The exception to that rule is a crowded disc. Because if you go from a 0.1 to a 0.2, that might be enough to give you a visual field loss. So the rule of thumb of optic nerve damage precedes visual field loss does not apply here when you have a crowded nerve. You'll have visual field loss before you have cupping in a small crowded nerve. One other case is, we'll finish over here, is a black female who came 51 years old. Again, she's had diabetes, family history of glaucoma, and if you take a look at her nerves here, again, if you look at them just in a glance, it doesn't really look that impressive that she has a normal left optic nerve. The right nerve, it looks a little bit larger vertically, but overall it seems to be intact. But if you look very carefully on the infratemporal aspect of this right eye, you will see that she has in her right eye a superior arcuate. A superior arcuate in the right eye, left eye is normal. And we repeat it again, and you can see even after a span of 1 year, she has the same superior arcuate. So this is real. So patients, and again, if you look at the nerve fiber layer OCT, there's a dip inferiorly to 1% of normal, indicating that this is real disease. And this is showing you here in the red-free and also in the regular photograph, along the infratemporal aspect, you can see bearing of the blood vessels. They're not obscured. So showing you an early nerve fiber layer loss. And that's a very important lesson to keep in mind, that you have to look not only at the optic nerve, but you should also look at the nerve fiber layer to make sure that you're not missing anything. And so the summary points in terms of disc asymmetry, to summarize our points, is that when you see someone with a very large optic nerve, what I've seen in my practice, they assume this for glaucoma and they treat the larger nerve. You should observe the disc photos side by side. Look at both the right eye and the left eye side by side so you can compare the optic nerves to make sure that you're not dealing with disc asymmetry and not glaucoma. Make sure you also measure the height of the disc with your slit lamp beam. That really helps me a lot. Measure the height of the slit lamp beam with your light beam and then just transpose it on the other eye, and you can get a sense of the disc asymmetry just by having the height of the thin beam to measure from the top to the bottom of the optic nerve, then go to the other eye and do the same thing. And you can detect clinically that could also account for the disc asymmetry. So in the absence of family history of glaucoma and normal pressure and open angles, it's best probably to observe those patients because otherwise you'll be treating them for life. And in terms of the crowded disc, I showed you two examples. The rule is usually that cupping or optic nerve damage precedes or comes before you get visual field loss. The exception to the rule is a crowded disc. So if you have someone with a very small optic nerve, don't get fooled that this is all good. Look at the background of the retina and look for those areas and look with the red free and you can detect abnormalities. And that will help you. I hope this is helpful and these are my points. Thank you.
Thank you.
Assalamu alaikum, bismillah. We're going to get started. If we can get the lights turned down because we have some video. They gave me 10 minutes to talk about surgical management of glaucoma using the new devices. So, inshallah, we'll go really fast and see if we can get through this all. Here are my financial disclosures. Now, when you think about the ideal glaucoma procedure, one wants it to be minimally invasive. These are all the good points that you want. in a glaucoma procedure. You want it to be bloodless, effective, efficient. You want it to treat a wide spectrum of glaucoma severity, minimal complications and risk profile. That would be great with glaucoma surgery. Can you imagine glaucoma surgery with minimal post-op management? That's also excellent. And at the end of the day, you're treating patients, so you would like your patients to be happy after surgery. So wouldn't that be also great? And at the end of the day, if you can get paid for your surgery, that would be also good. So the present surgical armamentarium right now has really exploded in the past couple of years. We used to just have maybe glaucoma drainage implant, trabeculectomy, Cyclo photocoagulation. But if you can look at this long list right now of different procedures that we have, it's really an exciting time in glaucoma surgical management. And not only that, we're now combining glaucoma surgery with cataract surgery. So we're attending to two comorbidities at the same time, making it very convenient for the patient. Just look at the amount of combined surgery that we have at our fingertips now. So one main thing, because the time is short, that I'd like to talk to you guys about is the mechanisms of surgically lowering intraocular pressure. So if you think about it, that there's one way to, the ways to decrease pressure surgically is one, decrease aqueous production, or two, promote the flow of aqueous to either a subconjunctival space or through the conventional outflow pathway, or through a suprachoroidal space. I mean, these are basically the mechanisms of surgery that we have right now. So if you keep these in mind, you'll understand what we're doing. If you were to think about, well, how do we decrease aqueous production as a way to surgically lower the intraocular pressure from an ab internal approach, one will have to discuss endocyclophotocoagulation. So ECP utilizes a 20-gauge handpiece that combines not only imaging but a light source and a laser. And you have the console right here, and it's an 810 nanometer diode laser. And as this video shows, you're basically applying laser to the ciliary processes with the end effect of having shrinkage and whitening of the ciliary processes in order to decrease intraocular production of aqueous. Now, the other mechanism is to promote outflow of aqueous. Okay, so now we're promoting the outflow of aqueous using the conventional outflow pathway. So the normal outflow pathway, let's try to rejuvenate that. And here's a pictorial. Recall that the normal pathway is through the trabecular outflow, trabecular meshwork, then through Schlemm's canal and the episcleral venous system. So if you are thinking about that, then you have to discuss ab external approaches, and one is traditional canaloplasty. And of course, with traditional canaloplasty, what we have is the formation of a scleral flap with a deeper flap inside, and then the utilization of the eye tract catheter to go around 360 degrees. You then tie a suture down into canal as well as viscodilate. And then you have good tensioning on Schlemm's canal. As you can see in this picture, this not only opens up the trabecular, intratrabecular beams, but Schlemm's canal and the distal outflow system. And then you close back up. So that's promoting outflow through, that's promoting aqueous out through the natural outflow system. Ab external approach, there's now an ab internal approach, and if we take a look at this video, I don't think we were able to turn down the lights, but hopefully you'll be able to see what's going on here. And if you were at my talks yesterday, you saw this video, and here we're basically doing traditional canaloplasty all from the ab internal approach. A small goniotomy is made here with a 27-gauge needle. The eye tract catheter is then implanted into canal advanced 360 degrees, and the goal to this procedure is really 360 degrees of viscodilation of Schlemm's canal and the distal outflow pathway to reestablish your conventional outflow system. So here we're taking out the probe. As we're taking it out, we're viscodilating. I usually, that was an old video, I usually do about 30 clicks right now for the whole system. You also have to discuss the iStent. The iStent was the first FDA-approved device and really paved the way for a lot of the mixed procedures. And in essence, you have this snorkel-like appearing device that's placed into the angle system so that you can bypass perhaps a pathological TM and have aqueous go right through this device into Schlemm's canal. If you also want to talk about promoting outflow through the natural outflow system, you also have to talk about the trabectome, and this came out quite a while ago, and in essence this is electroablation of the trabecular meshwork and the inner wall of Schlemm's canal. So you're essentially ablating this whole area and allowing fluid to go out into Schlemm's canal. A non-electrical, if you will, way of doing this is the Cahook dual blade, whereby you're able to literally remove trabecular meshwork tissue and expose Schlemm's canal. There's also a device called the Hydrus, and with the Hydrus, it's a rather large device, several clock hours, and this is implanted in the angle system to create somewhat of a scaffolding to dilate and permanently support Schlemm's canal and promote aqueous egress out of the eye into the natural outflow system. This is a pictorial of, or actually a picture of the Hydrus system device in the eye, and you can see that it spans several clock hours here. So this is an actual device in the eye. Now, if you want to promote a decrease of intraocular pressure, one of the mechanisms we mentioned earlier on was through the subconjunctival space, and if we talk about an ab-external approach, one has to consider trabeculectomy with the adjunct of the utilization of the express mini shunt. And I primarily, when I do trabeculectomy, I primarily do it with the express shunt. And so this is the device here, this is the express shunt, you have the foot plate here, and you have, this is what the device looks like. You have an opening in the device on the side as well as at the distal end. It comes on an injector, and if we take a look at how this is implanted, so this is a Limbo-based trabeculectomy. You go in with a 25 gauge needle, and then you simply implant the express shunt. And you lay your flap back down. Of course, this is follows the true steps of trabeculectomy, in that you have to, of course, lay your flap back down and then put your sutures, as you can see here, depending on how much egress you have. We should also talk about the Infocus microshunt. Now, this is under clinical investigation in the United States. I'm a primary investigator. We're on phase 2 now of this. And in essence, what this is a small device that actually has an outer diameter of 350 microns. The lumen diameter is 70 microns, and it's about 8.5 millimeters long. It's a flexible device that's very biocompatible and is placed into the anterior chamber through a small scleral tunnel under conjunctiva. Mitomycin C is used with this as in trabeculectomy. Now, if we look at an ab-internal approach, one, of course, has to talk about the Aquasis or the Zen stent, and a good pictorial of this is the implant itself is on an injector, and from an ab-internal approach, here you can see from an ab-internal approach, you're introducing this device so that it sits in the anterior chamber as well as distally under the subconjunctival space. Now, this is also combined with subconjunctival injection of mitomycin C, so keep in mind that the past two devices do use mitomycin C. And this is what the Zen implant looks like. inside the eye, and the thought process is aqueous goes through this implant and is draining outside the eye under the subconjunctival space. One of the last mechanisms of decreasing intraocular pressure that we mentioned was utilizing the suprachoroidal space. And from an ab internal approach, of course, we have to discuss the CyPass, and that was just approved in the United States and has FDA approval. And the CyPass is a microstent delivery system in that it's placed in the suprachoroidal space from an ab internal approach, so angle-based surgery here. And if one were to take a look at this video, it's placed underneath your pigmented trabecular meshwork in the suprachoroidal space. It's implanted. It should go in smoothly. If you have resistance, then you're not in the correct place. And you simply deposit it in the suprachoroidal system and hopefully allow the aqueous to go through the device into the suprachoroidal space. So hopefully we're able to quickly discuss some of the newer devices that have come out, as well as also get an understanding of the different ways we can try to decrease intraocular pressure with these newer devices. I thank you for your time.
So normal tension glaucoma, as you know, is a chronic progressive optic neuropathy with characteristic optic nerve head changes and visual field loss. In the presence of physiological IOP range, it's always less than or equal to 21 millimeters of mercury. And this definition is important to make a distinction between normal tension glaucoma compared to primary open-angle glaucoma. In the United States and Europe, it accounts for about 20 to 40% of cases of open-angle glaucoma. However, in some parts of the world, such as in Japan, it's extremely prevalent and accounts for about 92% cases. The pathophysiology of normal tension glaucoma involves both IOP-dependent and IOP-independent factors. So although the IOP is in physiologic range, these optic nerves have enhanced sensitivity at physiological IOP and are likely to be damaged. Therefore, the IOP-independent factors are very important, and these include local and systemic vascular dysregulation, mechanical weakness of lamina cribrosa, and neurodegenerative factors. This is an active area of research, and we are hopeful that in the future we'll have some treatment modalities targeting these independent factors. When taking care of patients with normal tension glaucoma, it's very important to get a good history. And if we're not asking certain questions, we can actually miss the diagnosis. With POAG, the three parameters that we look at are disc, field, and pressure. But with normal tension glaucoma, optic nerves can be quite tricky in terms of interpretation, and it's important to make sure there's no underlying trauma, inflammation, or infection. It's also important to rule out any ischemic or compressive etiology. Many of these patients also have compromised ocular perfusion, and we have to elicit an underlying history of sleep apnea syndrome, Raynaud's phenomenon, migraine headaches, anemia, hypotension, hypertension, and if any of these exist, they need to be treated. So when we're looking at the optic nerve, there are some clues which may help us point in the direction of normal tension glaucoma. Keep in mind, when you look at the neural retinal rim in these eyes, there tends to be some asymmetry. Also, these eyes often have like a focal notch, and it's usually found inferiorly or infratemporally. More localized retinal nerve fiber layer loss, which is usually in the distribution of that focal notch. Disc hemorrhages, you can see this with any type of glaucoma, but you see them more frequently with normal tension glaucoma. And I will tell you, a lot of physicians, even the trained glaucoma specialists, miss optic disc hemorrhages. You have to have a systematic clockwise approach, because if you're not looking for them, you can easily not find them. Also, peripapillary atrophy is associated with both increased incidence and progression of normal tension glaucoma. Moving on to visual field defects, these are usually localized and they appear to be centrally next to the fixation. It's not unusual for me to see many patients with normal tension glaucoma who present with dense paracentral defects at their initial presentation. So here is a patient who has early normal tension glaucoma. If you look at the optic nerves, we see moderate cupping. There is a tilt here. there's peripapillary atrophy, the thinning is more pronounced temporally and infotemporally, and in the right eye, there is a disc hemorrhage at 7 o'clock with a localized retinal fiber layer. I'm sorry, the pointer's not working, that's why I can't show you, but I think you can see that distribution, the arc distribution of the retinal fiber layer loss. The visual field here is normal, so this patient has early pre-perimetric normal tension glaucoma. Now keep in mind that 50% of ganglion cells can be lost before you see functional deficit. And in many of these patients, I do other types of visual field tests such as FDT or SWAP to determine early loss. This is a patient who has moderate normal tension glaucoma. In the right eye, you can appreciate that notch inferiorly, and it corresponds very nicely to that superior arcuate defect. And here is a patient who has advanced normal tension glaucoma, and you can see optic nerve cupping in both eyes, left optic nerve being more involved, and you can see functional loss both superiorly and inferiorly in the left eye. Now, I want you to take 2 points from every presentation that I'm going to give today, because I have so many presentations. If you can just take 2 points from each of my presentation, I'm happy. This is an important slide because a lot of times my trainees and my younger faculty members are confused as to when the patients need neurological evaluation. Thank you. And this slide gives some highlights as to when you have to think there may be underlying neurological condition going on. If you see marked asymmetry or unilateral optic nerve damage, think of an underlying neurological situation. If there's unexplained vision loss, if there's color vision deficit, if you see more pallor than cupping, if visual field defects are not corresponding to optic nerve status, that's really important. If they don't fit, then it may not be the glaucoma, it may be neurological disease. Often, as you already know, with neurological deficits, we see vertically aligned visual field defects. Also, young patients' age. If you have patient less than 50 years and pressure is normal, but the optic nerve is looking funny, pay attention that this could be something more than just glaucoma. Moving on to treatment, I want to discuss the collaborative normal tension glaucoma treatment study. If you look at the date, this was published almost 20 years ago. But this is a very landmark study, and the results are still clinically relevant in 2017 because it has helped us understand the natural course of this disease. So in this study, there were 2 arms. One arm, the patients were just observed without treatment until there was evidence of deterioration. And once that was noted, then treatment was started. The other arm, treatment was started immediately, either with medical therapy, laser, or filtration surgery. The goal of IOP lowering was quite aggressive, 30% reduction. That's quite high, and that's not often possible, especially when you're dealing with a disease like normal tension glaucoma, because we're starting with low pressure to begin with. It's much easier to lower IOP when you start with higher IOP. So this was very aggressive IOP lowering, and that's why they used any of the combinations in terms of treatment intervention. The endpoint criteria or the progression criteria included visual field progression and optic disc changes. Visual field progression was defined as deepening of an existing scotoma, expansion of an existing scotoma, or a fresh scotoma in a place which was not there previously. The endpoint or visual field progression was seen in 35% of the control eyes, compared to 12% in the treated eyes. So clearly there was benefit of intervention. Many patients in this trial developed cataracts, and the highest incidence of cataract formation was seen in eyes which required filtration surgery. And that's not surprising because we know cataract formation is accelerated with trabeculectomy. This is the other slide that I want you to pay attention to. Question number 1, does IOP play a role in pathogenesis of normal tension glaucoma? The answer is definitely yes. Lowering the IOP by 30% reduced visual field progression from 35% to 12%. Number 2, what is the natural course of normal tension glaucoma? The answer is it is highly variable, but it's typically small and slow. 50% of the patients did not progress. And half of all untreated cases did progress within 7 years. So 50% are not progressing, other 50% are progressing. How do we know, as clinicians, who do we need to treat and not treat? Well, fortunately, there were some risk factors identified in this trial, and these are the 3 main risk factors you need to pay attention to. If you're dealing with a female patient, if the patient has history of migraine, and if you see disc hemorrhage, you have to be more aggressive in lowering your intraocular pressure. Your target range has to be lower. The other study that I want to mention is the low-pressure glaucoma study. In this study, there were 178 eyes with normal tension glaucoma. There were 2 arms. One arm received brimonidine, 0.2% BID, and the other one was treated with timolol, 0.5% BID. The follow-up was a little more than 2 years, 30 months, and primary outcome measure was visual field progression. If you look on the left side, patients who were in the brimonidine group were statistically less likely to have progressive visual field loss than compared to those who were on timolol. So as you can see here, the brimonidine group has much lower rate of visual field progression. But if you look on the right, if you look at the IOP reduction compared to baseline, both treatment arms did equally as well. So why is it that the brimonidine group did better in terms of preservation of visual function? The answer is not very clear. Maybe it has to do with some unknown IOP effect. The graph that I showed you was related to mean intraocular pressure. Perhaps brimonidine may be more effective in lowering IOP with diurnal peak or nocturnal IOP. Or maybe it's working through a different mechanism, through an IOP-independent process or potential neuroprotective effect. Clearly, more work needs to be done in this area, but when I see these patients, I actually put them on alpha agonists. Moving on to trabeculectomy. As I mentioned to you in this trial, 30% IOP reduction was necessary. And how can you accomplish such a high reduction, usually with surgery? It's not surprising that 43% require trabeculectomy. The challenge when you do trabeculectomy in these eyes is that there's a very narrow therapeutic range between normal IOP and hypotony. So one has to be very careful, and how do you do that? I mean, you have heard a lot of lectures from myself and Dr. Issam about express glaucoma filtration device. This is one type of glaucoma where I would say glaucoma, the express device is very, very helpful because the opening is very uniform. And we have seen from many studies, retrospective, prospective studies, clinical trials, that the efficacy of express shunt is similar to standard trabeculectomy, and the complication rate is much, much lower. And this is one type of glaucoma where you don't want hypotony. The other thing is anti-metabolites. This is also tricky because we're starting with low pressure to begin with. How do we achieve much lower pressure? We have to use anti-metabolites. But we do know in these eyes, this may lead to hypotony. So you really have to be very judicious about choosing the concentration and duration of anti-metabolites. And I wish I could give you some, pearl on this, but I think it has to be based on your own experience as to what works best in your hands. Other considerations. As I mentioned before, this type of glaucoma can have other vascular issues. It is really important to have a team approach. Do not hesitate. Contact the internist. Find out if there's any underlying cardiovascular disease and treat that condition so you can increase optic nerve head perfusion. If you review the literature about calcium channel blockers, it has been proposed for normal tension glaucoma, especially in patients who have hypertension. And there are 4 different classes of calcium channel blockers, and these can actually enhance optic nerve flow, blood flow to the nerve. However, these medications have not been evaluated in large clinical trials yet, so keep that in mind. Well, thank you so much for your attention.
Bismillah ar-Rahman ar-Rahim. Sorry for delay. We discussed yesterday the videos about Express. Today we'll discuss shortly about the implant itself and how it is work. And we will discuss a pilot study about Express in our institute in King Saud University. As we mentioned before, that glaucoma surgery either work by subconjunctival filtration or mix. And as we mentioned that, in spite of mix is less invasive, but there is question mark about the efficacy and the productivity. And still, in spite of most recent surgeries about glaucoma, non-penetrating surgery, interno, still the trabeculectomy is the gold standard surgery for glaucoma. The complication avoidance with glaucoma surgery, as mentioned in previous lectures, hypotony, shallow anterior chamber, and leakage, and many post-operative complications usually due to direct result of poor surgical technique and also the adverse effect of the use of mitomycin C. And definitely the long time of the procedure. In trabeculectomy, as you know, the iridectomy is mandatory in all trabeculectomy surgery. And as we mentioned, that it connects the posterior chamber to anterior chamber to subconjunctival space. And also iridectomy is important because it will prevent pupillary block post-op. And this is what we like to see after trabeculectomy surgery, planchet formed diffuse white bleb with no leakage and no signs of infection. And this is the complication we don't like to see after surgery. So does Express add something to trabeculectomy? This is what we will talk about now. As we know, Express is made of rigid stainless steel, same as cardiac stent. It is about 2.6 millimeter in long. Internal lumen, there is two sizes, 50 micron to 200 micron, biocompatible, and MRI head is permitted. As you can do it, you are not supposed to do MRI within 2 weeks of implant of Express. You can do after 2 weeks. In spite of that, there is no problem to use MRI. The indication mainly in open angle glaucoma types. You can use it in chronic angle glaucoma, provided you have PI and approach open angle, but better to avoid in extreme narrow angle. Anatomical factor is very important. You should look for scleral thickness and angle anomalies. Preoperative preparation, as we mentioned, this is very important to look for the mobility of conjunctiva. You should have healthy conjunctiva before you plan for any glaucoma surgery, not even the Express implant. Gonioscope is very important to look for the angle and to look for the lens status before you go. And this is the surgical limbal anatomy. It's very important to know the anatomy of the limbus when you dissect, so you know the site of introduction of the Express. Otherwise, if you introduce it anteriorly, you may have problem, and also posterior it may be blocked. This is the site between the white and the gray area of the trabecular meshwork. And this is the shape of implant inside the anterior chamber. And as we mentioned, that Express is just a refinement of trabeculectomy. But we advise to add more suture in Express because you have an early hypotony, severe hypotony, post-op if you put loose suture. So better to add more suture and titrate by suture lysis you're suturing. Post-operative management, as any glaucoma surgery, topical antibiotic and topical steroid, but here there is no atropine as we are giving mandatory in after trabeculectomy. Meticulous follow-up is very important because of possible suture lysis, needling, and the mitomycin C, which is more frequent in cases of Express. High intraocular pressure sometimes occur due to fibrosis. It is the same problem of trabeculectomy of failure, which is fibrosis of episcleral tissue and closure of the fistula. So you are dealing post-op with Express implant like you are dealing with trabeculectomy. So what is the difference between TRAB and TRAB Express? Intraoperatively, anterior chamber shallowing, tissue trauma is less, the bleeding is less, and time of surgery even is less. Post-operatively, the hypotony, especially if you add more sutures, is less. Shallow anterior chamber flat, and you are not seeing. Choroidals are less, and hyphema, and important visual recovery, usually very fast after Express implant. And this is in short pilot study in our institute in King Abdulaziz University Hospital in Riyadh for 19 patients. This is the patient characteristic mean age of 50.9, the 12 male and 7 female. This is a systemic abnormality in these patients. One patient bronchial asthma, diabetic, 12 patient hypertensive, 11, and one ischemic heart disease. A preoperative diagnosis and disc cupping. There is 2 patients of neovascular glaucoma, 6 patient primary open angle glaucoma, 5 patient chronic angle closure glaucoma, and pseudoexfoliation, 2 patient uveitic, 2 patient juvenile glaucoma 1, and combined mechanism glaucoma 1. Previous surgery done in 3 cases, non-penetrating deep sclerectomy, which is failed, and 2 trap before failed, and 1 argon laser trabeculectomy. A second procedure done, there is 2 patients done trap express with phacoemulsification. This is the pre and post intervention, and this is, as you can see, the intraocular pressure is statistically significant, improving before surgery. It was, the mean was 25 to 14, as well as the number of medication decreased from 3 to 0.3. As you can see in visual acuity, there is no change in visual acuity, which give you hint also that this is advantage of express over trabeculectomy. And this is the success rate after follow-up of 11 months. You can see the complete success rate is about 80%. We have 4 cases failure. 1 of them is qualified success. And the majority of all cases failed due to bleb fibrosis. We did suture lysis and the mitomycin injection. And 1 case of uveitic after 1 month failed, and the other one failed after 1 year. Other cases failed after 1 year. What about the clinical trials and the study about express? This is a Netland study, and it shows the efficacy comparison between 50 patient eyes of trap and another eyes of trap express, in which you can see this red line in which the hypotony is less and the choroidal is less in case of express. And in spite of comparable success rate between both groups. That means usually the success rate is equal in both groups, but the complication is less in express. This is the long study again, which show after 2 years survival of the IOP control. You can see the IOP below 15 and IOP below 18. Still the express show 71 in IOP reduction success compared to trap 48, and also below 18 still express is higher number of success as regard intraocular pressure control. This is another study by Netland, which he combined the express with phacoemulsification, and also as regard medications and as well as intraocular pressure control. There is no difference in success rate as regard whether you do it express alone or express combined with phacoemulsification. Prof. Sarwat Salim also have very interesting study about the white and the black Americans, in which she conclude that the less modification of glaucoma filtration surgery may be better surgical option for African American, give its potential advantage of no tissue removal. But again, all study go in one direction. You may have another opinion for express. This is by Elad, in which he has 100 patients of 100 eyes, in which 61 trabeculectomy, 39 express. And he showed that the intraocular pressure is comparable between both of them medications. Otherwise, complication is almost equal between both groups, and he concludes that standard trabeculectomy and express shunt has similar efficacy and safety profile, as well as express shunt is considerably more expensive, and its use may be unjustified, especially as a primary procedure. So does express add something to trabeculectomy? The profile of express device produce IOP reduction that at least good as trabeculectomy, and they may have some possible advantage. Post-operative complication rate are similar and sometimes lower with express compared with trabeculectomy. Definitely iris bleeding, vitreous prolapse is not an express, but malposition and dislocation can occur. Subsequently, interventions are similar in both approach except for laser suture lysis, which may be more required with express mini shunt. For selected patient, eliminating peripheral iridectomy are needed. Sometimes you don't want to do iridectomy, especially in severely inflamed eye. But the cost-effective and the efficacy of device is question mark. The potential effect of express device on corneal endothelium, which is very important point, but only long-term study will address this point. Prospective randomized controlled trial with sufficient number of patients and follow-up are warranted strengthens the body of evidence in using Express. Thank you very much.
So this time they gave me 20 minutes, so I'll take a little bit of time to go over this a little bit slower. So we're going to talk about the novel uses of endocyclo photocoagulation. So endocyclo photocoagulation, we talked about this a little bit earlier. And if you keep in mind it uses a 20-gauge handpiece that combines the imaging light source and laser, and here's your console. And usually when we think about endocyclo photocoagulation, we think about it in combination with cataract surgery. So what one does is take out the cataract, do their irrigation and aspiration. At that point, you inflate the sulcus with Helon, and then ECP is done anywhere from 180 to 360 degrees, and then that Helon is cleaned up. So when you think about ECP, this is what you guys are typically accustomed to seeing, and that is using ECP for the reduction of intraocular pressure. So, I was one of the earlier adopters of ECP about a decade ago, and after using it quite a bit, and not being so overwhelmed with the decrease in intraocular pressure, I started thinking about, well, how else can we use this amazing technology? Because truly the view inside the eye is spectacular. So how else can we use ECP? And so we described a way to visualize and treat a cyclodialysis cleft using ocular endoscopy. And the purpose of this study a while back that we reported at one of the national meetings was to report the novel method for definitive diagnosis and primary closure of a chronic cyclodialysis cleft using the ECP and diode endolaser photocoagulation in a child who actually sustained a blunt ocular trauma. So I'll never look at a paddle ball again the same way. This was actually the mechanism by which the kid had an injury to his eye. This was an 8-year-old kid whose mom was actually an emergency room physician. So this 8-year-old kid had a blunt trauma to his right eye, and his pediatric ophthalmologist actually examined him under anesthesia. It was inconclusive. He couldn't really see anything on exam, but treated medically on the suspicion that there was a cyclodialysis cleft because the kid presented with hypotony. So he was actually referred to me at Dean McGee Eye Institute at the University of Oklahoma for persistent visual reduction in hypotony. And his best corrected vision was 21/25, and he had a little bit of mild myopia. His intraocular pressure was 3, and he actually had an RAPD in his right eye. The anterior chamber was shallow, and there was early posterior capsular lenticular changes. I attempted to do gonioscopy on this 8-year-old kid in the office, but no angle structures were visualized as expected because of the hypotony and shallow chamber. Now, when we looked at the fundus, of course, he was dilated, as I mentioned. The fundus did show macular stria, so we did see some hypotony maculopathy. And as you can see here, the nerve was definitely swollen. Now, when we looked at UBM for this little boy here, this was actually attempted during an exam under anesthesia, but it really didn't definitively locate or demonstrate the extent of the suspected cyclodialysis cleft. So the small arrows here denote the shallow choroidals that this boy suffered from, and perhaps the large area was perhaps the area of the cyclodialysis cleft, but we couldn't tell for sure. So if we review the angle system really quickly, of course you have your ciliary body, followed by your scleral spur, trabecular meshwork, and Schwabe's line. And if we look at blunt trauma, I'm at a teaching institute, so we always have to review this with residents. Of course, angle recession is tear between the circular and longitudinal muscles of the ciliary body. And a cyclodialysis cleft is actually a separation of the ciliary muscle fibers from the insertion at the scleral spur. And so then hypotony is created from a direct communication between the anterior chamber and the suprachoroidal space. So, diagnosis of a cyclodialysis cleft, usually from a non-invasive way, is done either by gonioscopy, so direct visualization. You can see perhaps where the cyclodialysis cleft is at, or UBM, or anterior OCT. But this requires patient cooperation and can be very difficult to do when you have hypotony and the collapsed anterior chamber, especially if you have a pediatric patient. Trying to do gonioscopy in the office can be quite a task. So why not use the endoscope to view and treat a cyclodialysis cleft? So keep in mind, one of the treatments for a cyclodialysis cleft is maybe argon laser therapy, but how am I going to sit this 8-year-old kid at the argon laser and have him cooperate with me while I shoot at his angle to try to get a closure of this cleft? So let's take a look at this video. So starting off the procedure here, I haven't entered the eye. I'm just basically using a simple 3-mirror lens here, and I'm going around the angle system looking at this view here, and I really couldn't identify any of the angle structures. At this point, I created paracentesis and inflated the chamber a little bit to help me look at the drains, the angle system to see if I can identify a cyclodialysis cleft. And we're going around. Now you can see some pigmentation of trabecular meshwork. And, when I start to focus a little bit more, there's a little whitening here. So there's a deep angle recession here, and then there's a little whitening, and then I noted that this is probably where the cyclodialysis cleft was. At this point, once I targeted where that's at, I used the ECP. This was the first time we've ever done this, and I just kept on applying laser to that area. My end stage was perhaps a lot of bubbling and maybe some trauma to the iris, hoping to stir up a lot of inflammation and hopefully closure of the cleft. Let's take a look at another patient here with the same technique. Now, this was a prisoner who suffered some trauma in the prison, was hit in the eye, and came with hypotony and a suspected cyclodialysis cleft. Of course, UBM was not conclusive, and so same technique here. Put the 3-mirror lens on, haven't entered the eye. This is in the operating room. I can't see any angle structures. As you can see, nothing is identifiable now. So at this point, we take the lens off. I'm going around 360, no structures. Take the lens, make a paracentesis, inflate the chamber with a little OVD, not overzealous reinflation of the chamber, but enough to allow me to see. And here we go again with the gonio prism, and we're going around. Now you can see structures. You can actually see the angle system here. So pigmented trabecular meshwork. We're going around. That looks okay. Of course, we have to keep up with the microscope, so we're refocusing, repositioning. And what do we have here? So I start, okay, well, what's this? So let's get let's zoom in here. And here is an area where there's quite a bit of recession, and you can see almost a small little hole here where the cyclodialysis cleft was denoted. Clearly, it's amazing how small this area can be and how much havoc it can have on the eye. So here's a beautiful pictorial right here of the cyclodialysis cleft. You can see that here. And once you identify where the cleft is at, then you make your wound accordingly about 180 degrees away. And at that point, we apply endoscopic laser, ECP laser to that area. You can see the bubbling effect here. And we just pretty much shoot as much as we can in that area to hopefully create some inflammation. Now, both of these cases remained hypotenuse for a good week or two. And so it was not until about a week or two of inflammation in the eye that all of a sudden their pressures went sky high, and we knew we had closure of the cyclodialysis cleft. Now, a different utilization of the ECP probe is when one considers the Ugg syndrome. So, yeah, uveitis glaucoma hyphema syndrome has long been a complication of intraocular lens placement and was kind of described in the early or the late 70s. Now, with the improvement of phacoemulsification and intraocular lens technology, there has luckily been a decrease in the diagnosis of Ugg syndrome, but it should be considered in a setting of recurrent hyphema. So the clinical diagnosis of Ugg syndrome can be difficult if there is no clear indicator that the lens is displaced. So it can be very difficult. So you have to have a high level of suspicion. Furthermore, UBM has been advocated as a diagnostic tool to identify the displacement of intraocular lens. However, this may not always be available or a definitive, it won't always give you a definitive diagnosis, as we'll see in the cases that I'm going to present. Now, we've actually presented this at some of the national meetings and our study showed endoscopic management of displaced IOL causing recurrent hyphema in a patient with pseudoexfoliation. So here we have a patient who comes in with a chief complaint that their vision has been blurry. It was a 73-year-old male that presented with waxing and waning of vision over the past 2 months, and he had previously been diagnosed with pseudoexfoliative glaucoma and denied any ocular trauma or injury. Now, he came in with a vision of 20 over hand motion, so he had hand motion vision in the right eye, and his anterior chamber has dispersed red blood cells throughout the AC and a small layered hyphema. You could see a little bit of iridodenesis on exam. He was pseudophakic, and then you can see a little bit of phacodenesis on exam. So the suspicion that something is going on with the lens was definitely there. Furthermore, there was no neovascularization noted on anterior exam on gonioscopy or on the iris, and there was no view of the posterior fundus. So we took a UBM of the right eye, and it really did not show any clear displacement of the intraocular lens or any other etiology for hyphema in the anterior chamber. And so at this point, the working diagnosis was perhaps this may be, there's high level suspicion for perhaps Ugg syndrome here. And so we boarded this patient for exploration with the ECP probe, hyphema washout, and because his pressures were at this point also uncontrolled and he had severe glaucoma, his Trab expressed number 2 in this. So quite a few things that we wanted to accomplish at this procedure. So the endoscope revealed when we got in, did a hyphema washout, the endoscope revealed that there was an inferior haptic of the intraocular lens that was displaced out of the bag and phimosed to the anterior capsule. And the end of the haptic was abutted against the ciliary body and posterior iris with a small amount of clotted blood posterior to it. So the ECP probe was what allowed us direct visualization. At this point, the MST scissors were used to amputate the haptic from the rest of the lens at the optic haptic junction. The MST forceps were then used to remove the haptic from the eye. The trabeculectomy portion was then accomplished. The lens was centered at the end of the case, and the remaining heme was washed away from the anterior chamber. So results were pretty good afterwards. His vision had recovered to 20/40. Keep in mind he was hand motion initially. His intraocular pressure was down to 11. I believe it started in the high 30s or low 40s, and the procedure was completed without incident. And the patient's been doing fine ever since. So if we take a look at the picture, here's the hyphema. And so we entered the anterior chamber to clear up the hyphema. Keep in mind there's some blood in the original trab site here. So here we are inside the anterior chamber. There's a lot of blood. You can see that there's a lot of blood in the anterior chamber, a blood clot. So you can see now that there's a haptic around this area. It looks like there was an explosion that's occurred inside the eye. Now there's a haptic that's kind of looking mysteriously up to no good here. You can see a lot of fibrosis, and you actually saw an area of synechia between the iris and this clotted blood. So this was the presumed area of issue. Now you can see the rest of the haptic was inside the bag. And so here with the MST forceps, of course, keep in mind the retina surgeons were next door. And I told them, hey, get ready, we might be needing you guys. So I entered the eye with the MST forceps, scissors, and actually cut off the haptic. And so this is all accomplished because we can see what we're doing inside the eye. You would never be able to see this without the endoscope. Now, there was a little bit of the haptic left over, and so I wasn't happy with that, so we got rid of that also. You can see the haptic there. And hopefully the inciting factor for the recurrent hyphemas, and so that was cleared there. And so luckily the lens stayed in place. We didn't have a dropped lens. Of course, this is one thing I do discuss with my patients, that there could be the possibility of further dislocation of the lens and need for further treatment. And so you can see the rest of the lens and the haptic. And hopefully we've taken care of the reason for their hyphema. So we do a hyphema washout. The anterior chamber looks a lot better. And so we're done with that case. Now, let me show you another case. So you have to have a high level of suspicion. This is a patient that had recurrent inflammation in the eye, and so they had some TIDs, recurrent inflammation. They actually made it to my office because they had steroid-induced glaucoma. So the comprehensive ophthalmologist was treating their recurrent iritis, thinking, well, what's going on? They've got a lot of iritis going on, years of steroid therapy, and then all of a sudden the pressure comes up. They come to my office because I've had experience with this. I said, well, maybe this is Ugg Syndrome. So we took this patient to the OR, and these are the still photos that you could see. You can see that the haptic, here I'll show you that the haptic is outside of the bag. Look at the ciliary processes just adjacent to the haptic. Look at the whitening there. There's some obvious trauma to these ciliary processes. If you take another look, look at the whitening here that you see amongst these processes. When I first looked at this, I said, man, this is pretty clear. Am I actually seeing what I'm seeing? Well, in order to figure out if it is what I'm really seeing, I wanted to take a view at the other side. Now, look at the other side where the haptic is. This is the other haptic. It's in the bag. And look at the adjacent ciliary processes. No whitening, no trauma. So it's at this point, and here's several other cases where let me show you a little bit of footage here. So you can see this is an older three-piece model here, and you can see where the haptic is actually abutting the ciliary processes with quite a bit of trauma to the ciliary processes. And you can see true Ugg syndrome here, where you have recurrent trauma to the ciliary processes, creating inflammation. Here's another case. Now this is a one-piece, and you can take a look at this haptic that was thought to be placed in the bag by the original surgeon, but actually was not. And with the endoscope you can follow it, and you can see again characteristic whitening of the area of the ciliary processes that have been traumatized. Haptic is clearly outside of the bag. Let's take a look at another case here. So here this haptic looks suspicious. It seems outside. The ciliary processes don't look too bad here. So, but it was outside of the bag. So what I actually did, I did not have to cut off the haptic here. You can see clearly that the haptic is outside of the bag here. And so what we simply did was go in with MST forceps and grab the haptic. We grabbed the haptic here, and we're simply just putting it back in the bag. I said, before I cut this haptic off, why don't I just try to implant it in the bag? And sure enough, back in the bag. Okay, I know my time is running up. Just quickly, I want to go over one additional aspect of how one can utilize the ECP probe, and that's for visualization of epithelial downgrowth of the inferior angle iris and corneal endothelium with means of the ECP probe. Now, we also described this at one of the national meetings. The purpose of this was to evaluate a unique approach to visualize and treat epithelial downgrowth using the ECP in a 64-year-old patient who had post-penetrating keratoplasty who developed signs of surgical complication. Now, epithelial downgrowth, keep in mind, the clinical prevalence has been reported, thank God, very low, anywhere from 0.09% to 0.12%, and it should be treated as it can have very devastating effects on the underlying tissue. And unfortunately, with epithelial downgrowth, you can get secondary glaucoma, decreased vision, inflammation, and destruction of ocular tissue. Now, there's greater than 95% of these untreated cases result in enucleation. So it's a devastating blow to the eye. And prior to this way of treating it, the only way to treat it was en bloc excision of the area, so taking out tissue, quite a bit of tissue, which was quite traumatizing to the eye and often led sometimes to the enucleation of the eye. Cryotherapy, very inflammatory, or argon laser therapy with the characteristic whitening. So here we have a 63-year-old male who underwent uneventful penetrating keratoplasty, pars plana vitrectomy at the same time, and an anterior chamber lens placement was put in, as well as a tube shunt placement in the eye. And post-operatively, the cornea specialist noted that there was this line. You can see this line here, and so that worried them. There was a distinct line of endothelial membrane can be noted on the corneal button here. And so if you take another look, you can clearly, within a week or two, you can see how this line has progressed. Obviously, very concerning. And so what we did here was use ECP to, instead of using argon laser therapy, ECP to actually apply laser to the endothelial surface, iris surface, underneath the iris, pupillary margin, inferior chamber angle, and the graft host junction. So in essence, I used ECP to treat almost the whole eye. And there was a whitening noticed throughout the area where the area was covered with this membrane, and a whitish membrane was then peeled off. So let's take a quick look at this. This is the last video, if you will. This is the patient that had endothelial downgrowth here. Epithelial downgrowth. And so I'm inside the eye right now, and the first thing that I noticed, the quality of the video is not as good. When you use ECP in the anterior chamber, there's a lot of light diffraction, so it can make your view pretty bad. But actually, what I was treating there was actually the endothelial surface of the cornea. And you saw a little bit of a strand there. That was the actual tissue coming off. And so here I'm treating the ciliary process. You can see white fibrosis in this area, and quite a bit of it here. Now we enter the eye again. And you can see this was an aggressive growth of tissue all along the processes. So basically I treated this whole area here with ECP laser. And keep in mind, I told you that he had a pars plana tube at the time of his penetrating keratoplasty. And of course, as a glaucoma specialist, I always want to take a look at my tube and figure out, hey, is it working or not? And so I couldn't help myself, but I actually treated the tube too. I didn't know if there was any epithelial tissue on the tube. You never know. But, you know, as all interested glaucoma specialists are, we want to take a look at that tube and see if it's patent or not. And alhamdulillah, it was patent, so we didn't have to do anything with the tube. Pressure was low, but this is a way to also treat epithelial downgrowth. I thank you for your time.
Assalamu alaikum wa rahmatullahi wa barakatuh. Actually, the ciliary destructive procedures are not attractive to any of us, but sometimes we are forced to do it. And for this technique, I think it is newer technology that we need to highlight on it, and we add it to our options if proven the efficacy of it. I have no financial interest to disclose about this technology. there is many destructive procedures have been tried over the last 3 decades, including diode laser and diathermy, also cryotherapy. Even ultrasound has been tried during the late 80s and early 90s. All of them have 2 major drawbacks for the non-selectivity of the destruction that might lead to severe ocular inflammation and unpredictable dose effect in terms of lowering the pressure. The ultrasound cyclodestructive has been tried earlier and also found to have some good effect about the pressure, but at the same time it has a lot of side effect and complications that make us also get it out of our list. Then group of people in France has worked on it to develop more advancement to be more selective and less side effect with high efficacy in lowering the pressure. The technique or the technology itself, it was developed as a cone or a touchable cone that will just apply the pressure to the eye, and this cone will have a coupling with a suction of about 30 millimeter that will suction the eye gently. Then after that we will put inside the cone, the coupling cone, the probe that has the transducer. The transducer has these six regions which will deliver the ultrasound to the eye. So this is the coupling cone, and this is the probe that has the ultrasound delivery, and it will be applied to the eye, trying to deliver the ultrasound high intensity to the ciliary processes. There is many evidence starting from 2011 by the same group who developed the technology in investigative ophthalmology. There is a significant lowering of pressure in all time over 1 year of follow-up. They divide the patients to 2 groups according to the delivery time of the ultrasound. 4 seconds and 6 seconds. Both group has the same effect regardless of the application time, and they conclude their study with the conclusion that the ultrasonic ciliaryplasty is ineffective and with a favorable result in terms of intraocular pressure and less complications. These are their graphs about their control, the result of the intraocular pressure. It came from around 30, and they maintain it in the range of 20s with less number of medications. The most common side effect or complication or side effect, let's say, not complication, in terms of short-term follow-up, there was hyperemia that will be improved after like 1 to 1.5 months, and also the ocular inflammation. There is another study from the same group after 4 years in the investigative ophthalmology with a multi-center study that showed also a good conclusion with a good result in terms of intraocular pressure, good result also in terms of side effect. Another group who are not related to the developing the technology itself, they have studied the technology and they end up with the same result, that supporting the technique and supporting that the destruction is more selective in terms of lowering pressure and more predictable in terms also of pressure and less complication on long-term follow-up. The most common, again, in all studies, the hyperemia and anterior chamber activities. The technique actually is very simple under local anesthesia with a retrobulbar or peribulbar. Also, there is some publication about using this technique under topical anesthesia. Those are the cone that will do the suction. This is the transducer. We will apply the cone, then we will insert the transducer inside it. The cone has 3 sizes. We have to do a measurement of white to white to know exactly which size of the transducer will apply, 11 or 12 or 13 millimeter. The technique will take around 3 to 4 minutes. And actually, I just have this video just to show you quickly how much simple is it. The technique will give through the transducer 6 seconds application of the ultrasound, then 20 seconds off through 6 points. So the total time of application is 3 minutes. Me and Dr. Al-Udaib, who is working with me in the same unit, we decided to have an observation of 10 patients who are absolutely have no other option other than this technique after trying at least 2 incisional surgeries and complete medications, including Diamox, or intolerable to Diamox. The patient's range, the pressure range pre-op ranges from 18 to 46. The least patient was on 4 medications, and 4 of them were on Diamox. The pressure, the highest point were 33, the mean, and it comes down in the first week to 14, then it comes up at 1 month to 16. Actually, we don't have more time to follow up. Still, we are running our observation. Number of medications, 6 of patients have 4 medications, and 2 have 3 medications. 4 of them have Diamox orally. At 1 week, 1 patient used 1 drop, 3 patients use 2 medications, and 4 of them on non-medications. At 4 weeks follow-up, 2 only without medications, and 5 with 2 medications, 1 with 3 medications. These are the more common side effects that we prefer to observe. This with the anterior chamber activity. We found the inflammation is improving with time with the help of steroid. Actually, at 1 month, it is very rare to have some activity in the anterior chamber. In conclusion, we think ultrasonic ciliary plasty is an alternative that's worth trying for lowering intraocular pressure in refractory glaucoma. Also, we think it needs more time to evaluate its effectivity and efficacy in maintaining favorable intraocular pressure at long term. The safety profile, we think it is somehow safe. We need to preserve it for non-responding glaucoma or cases with high chance of complications with incisional surgeries. Thank you very much.
Bismillah ar-Rahman ar-Rahim. So, coexisting cataract and glaucoma are commonly encountered in our glaucoma clinics. Advances in surgical technique resulted in better outcomes of combined procedure as well. Reports in the literature suggest that there is a weak evidence that trabeculectomy alone lowers the IOP more than a combined procedure. Actually, combined surgery generally achieve additional 3 to 4 millimeter IOP lowering effect. So the advantages of combined procedures in glaucoma in general are that they offer less psychological and financial burden by avoiding additional procedure, early visual rehabilitation, low risk of early post-operative IOP increase compared to phacoemulsification alone, and significantly increase the IOP lowering effect. On the other hand, phacoemulsification alone might cause significant short-term raise in the IOP, and trabeculectomy is associated with a progression of pre-existing cataract. So just to have a brief overview about trabeculectomy, which was first described in 1967. So it's based on the principle of guarded filtration under guarded flap, where the aqueous will flow from the fistula to the subconjunctival space. And the initial success rate was almost reaching 85%, which was increased since the introduction of mitomycin C. However, the introduction of antimetabolite resulted in more post-operative complications. The advantages of trabeculectomy in general, that it lowers the IOP, it's a cheap procedure. However, the disadvantage is that it's having the same techniques since its introduction. There are some modifications, if you follow the study of Pinkow, in the term of the conjunctival flap being fornix-based better than limbal-based, to have a low diffuse blip. We have high rate of complications, which some of them are vision-threatening actually in trabeculectomy. It's cataractogenic. And there is a high intermediate and long-term failure, and the lifetime risk and frequent visits are also existing as well. It's indicated in patients in which there is a failed medical therapy, and in which the patient needs low IOP. However, there are some certain risk factors of failure that we need to keep in mind, like dark skin pigmentation, prior surgery, conjunctival scarring, aphakia, ocular surface disease, uveitis, neovascular glaucoma, and prolonged use of anti-glaucoma medications. On the other hand, endoscopic cyclophotocoagulation, or ECP, it was first described in 1992 by Uram, in which there is a direct visualization of the ciliary process, so you will have direct treatment. It will result in fewer post-operative complications. And basically, the laser unit for ECP, which is nowadays from Beaver, Visitic, incorporates an 810 diode laser pulsed continuous wave energy and a 175 watt xenon light, up to 300 nowadays, and with helium neon laser aiming beam with recordable video camera imaging. And there are some different sizes of the probes, ranging from 19 to 23 gauge. The optimum focus is 0.75 millimeter from the probe tip, and the endoscope provides 70-degree field of view, which is now modified with the new probes and size. And the main unit is compact and portable, and the maximum power output reaches 1.2 watts. The indications of ECP are targeted IOP in the mid-teens, open or closed angle, mild to moderate glaucoma. Sometimes you can use it in severe glaucoma with caution. Avoid in inflammatory glaucoma and uveitis, and you should avoid it mostly in patients with pseudoexfoliation glaucoma because of the damage to the blood aqueous barrier with long-term chronic postoperative inflammation. With cataract surgery, it can be done, pseudophakic patient, to some extent aphakic patient. You can do it in failed previous filtering surgery and in plateau iris. So in general, the advantages are low risk of hypotony inflammation compared with transscleral diode laser cyclophotocoagulation, used at any time of the disease. In advanced disease, you can use it with caution. Easy to use and to do. Disadvantages are it's still cyclodestructive procedure, and it can result sometimes in chronic or severe inflammation, and medication burden is not affected so much. Some of the complications are IOP spikes, acute graft rejection if done in PKB patients, severe inflammation, hyphema, and hypotony. So the aim of our study was to compare, the 2 years outcome between phaco-ECP and phaco-trabeculectomy in coexisting advanced glaucoma and cataract. This is a retrospective comparative case series which was done in KUH and included patients who underwent at least or who had at least 24 months of follow-up. The main outcome measures were the IOP, number of anti-glaucoma medication, best corrected visual acuity converted to logMAR, and postoperative complications and surgical success rate as well. We compared with the data were collected for the age, gender, MD, pre and postoperative best corrected visual acuity converted to the logMAR, IOP, number of anti-glaucoma medications, and postoperative complications. Variables were evaluated using student t-test, Wilcoxon rank test, Mann-Whitney, and the chi-square test. Generally, we recruited 50 eyes of 25 patients. One eye underwent phaco-trab and the other eye underwent phaco-ECP with no previous ocular surgery. The diagnosis was mostly primary angle closure glaucoma, 64%, primary open angle glaucoma, 20%, and pseudoexfoliation glaucoma. Most of the patients are of the older age group. The pointer is not working anyway. And most of them had advanced disease in which the MD was more than -12. If you can see here on this schedule, or sorry, on this table, The IUP between both groups was almost comparable in the baseline and the number of anti-glaucoma medications. However, on the follow-up, if you compare between both groups in the first 3, 6, 12, and 24 months, we can see that there is significant difference between the phaco-ECP group and the phaco-trabeculectomy group in the term of the number of anti-glaucoma medications. If we compare within the group, during the follow-up between the baseline parameter and the first 3, 6, 12, and 24 months, we can see that the trabeculectomy group achieved significant difference except on the first year, while there is no statistically significant, although there is a drop in the ECP group. This graph here shows that the number of anti-glaucoma medication decreased and the burden of medication decreased in the trabeculectomy group compared to the ECP group. However, the IUP lowering effect was almost comparable in both groups. So, in both groups, there was no statistically significant difference between both groups in the logMAR. There was significant difference in the IUP on the first and 6th month. In the ECP group, there is no change in the IUP nor number of anti-glaucoma medication. However, in the phaco-trabeculectomy group, there was a change which was significant in the number of anti-glaucoma medication. Looking at the complications, in terms of severe inflammation, 3 eyes in the ECP group had severe, or chronic post-operative inflammation because of the aggressive treatment, compared to 1 eye in the phaco-trabeculectomy group. IUP spike occurred in 1 eye in both groups. Hypotony occurred in 2 eyes in the trabeculectomy group compared to none in the ECP group. And wound leak occurred in 2 eyes in the trabeculectomy group compared to none in the ECP group. The absolute success rate was achieved in 3 eyes in the phaco-ECP group compared with 12 in the trabeculectomy group. Qualified success was 22, meaning that the IUP was controlled below 21 with medications in 22 eyes in the phaco-ECP group compared with 12 eyes in the phaco-trabeculectomy group. However, we have 1 failed eye in the phaco-trabeculectomy group because of leak and secondary blebitis. So in conclusion, phaco-ECP and phaco-trabeculectomy offers almost a comparable short-term IUP outcomes. Phaco-trab seems to decrease the burden of anti-glaucoma medications compared to the phaco-ECP group on the short term. Research is on the way now in the University Hospital to compare the efficacy and safety among different glaucoma entities. Thank you very much.